So good night, everyone, and back to our OCMO didactics. Today, we are just one step far from finishing the cervical, or two steps far from finishing the cervical cancer module. And tonight is a very special night, having a very special lecturer today, a dear friend, Dr. Saad Alrashidi from King Fahd Medical City, Riyadh, Saudi Arabia. And he was humble enough to accept our invitation to be with us and to give us his time and effort today to speak about the basics of clinical oncology and that our residents need to know about. So, Dr. Saad, the floor is yours. We are very happy to have you today. And then we are ready to hear your slides. Please make the slides full screen and you can start.
Thank you very much, Prof Basil, for the invitation. And really, I appreciate interacting with your fellows and the attendees. And I hope I will contribute with what I will do tonight. So we will go through the cervical cancer management, mainly from radiation perspective. I'm a radiation oncologist, as Prof Basil mentioned. And I will lay over the basic view of us as radiation oncologists, what you need to know from radiation oncology, and we will go through the management approach. We treat probably one of the biggest cervix patient in the whole country in Saudi Arabia here. And just a little bit about the radiation oncology. I'm not sure if you already had the introduction. Radiation been there for so long, and almost like over 100 years now. And really, we say 60% of patient need in general radiation treatment, but probably nowadays more than 80%, I would say. It's very essential in the cervix cancer management, as you know, for the radical treatment we'll be talking about, and also in the metastatic setting. So what does radiation do? Really very simple. It kills the DNA, like also the chemotherapy agent that damage the DNA. We mainly damage the DNA by indirect damage. So when we give the radiation, it causes a direct and indirect damage depending on the modality what you're utilizing for the radiation, either photons, I will be explaining, or proton or particle therapy. So mainly indirect damage, if you are asked about in your exam, the damage from the radiation therapy or the photon therapy, and by producing the free radical later on, like even the chemo agents that they produce damage at the level of the gene or the DNA. And we call it fractionation. Our treatment is extended over several weeks, if not months. And typically for the cervix cancer, we give 25 fractions. It means fractionated daily treatment from during the treatment, and also limited fractionation during the palliative therapy. So we believe in the radiobiology, which is, the change at the cellular level when it damages the DNA, and the radiation damages the normal and abnormal cells. So the good thing, the abnormal cells will die because they are not normal, and their DNA and function of their cellular activity is not the same of our normal tissue that regain the damage after a certain time. That's why we fractionate. We give a certain small dose of radiation during a few days or a few weeks. And then the cells repopulate, which is the normal cells, as well as the cancer cells. But the cancer cells continue to struggle and they die. That's why you see the response. And I also emphasize for the trainee, when you see the response over several months, it doesn't mean that you need also the radiation again. So when we give the radiation, it damages the DNA, and some cells will replicate, but with a few months, not necessarily a few days, and then they continue to struggle out and die. That's why when I come to the imaging, I'll explain why the effect of, for example, the PET scan, the response is seen after 3 months or so, and as well as with some chemo agents. So the cells continue to die during the during the follow-up of the patient, even the treatment already over. And then the redistribution, the cells also redistribute themselves. That's why we choose to fractionate or cut the treatment into several treatments. And it gives the cells more vulnerable to be killed when they redistribute themselves. It's like, when you are relocating yourself, it's easy to be killed by the radiation treatment or the photon therapy. Reoxygenation also, when the cells, and that's also the benefit of giving the chemotherapy with the radiation, because it gives a little bit of kill of some cells, and then the other cells will reoxygenate, and then the hypoxic cells will be more vulnerable to the kill by the radiation modality. So there are many teams of the radiation depending on your environment. I think in Egypt a little bit different, because there's oncologists, not necessarily radiation oncologists per se, that treat also give chemotherapy as well as the radiation. But in North American, for example, environment, you have the radiation oncologist alone, you have the medical physicist as well, part of the team, the dosimetrist who calculate the dose and produce the plan or design the package for the patient to be treated with the machine, as well as the radiotherapist who deliver the treatment at the machine itself, or they are the technologist, the same for the technologist in the OR or the nurses, and the radiation oncology nurses, of course, like any nurses. So it's a huge team run again by the Department of Radiation Oncology. So the treatment process involves, of course, referral and seeing the patient from you as a surgeon, and from others when we see the patient in the consultation. We do the preparation or simulation. We prepare the patient for the radiation and the treatment planning, which is the designing the whole planning for the patient to make sure every patient's own package is suitable to be delivered at the machine. Of course, there is quality assurance, the same what you have as a surgeon when you review your process in the OR, etc. So that's roughly about overview for the radiation. Any questions so far about the basic fundamental in radiation? And have you guys had any lecture on radiation as fundamental principle before?
Thank you, sir. I think that no questions now from the floor. Thank you.
Okay, perfect. Then we will proceed now to the actual topic, which is the cervix cancer. Question to all of you: what staging do you follow nowadays as a surgeon and as a trainee? Which one? 2018, 23? What staging are you following?
The cervix?
Yes.
Yes, 23.
23. That's perfect. So I put, both, but, I removed that 2018 because, there are some trial run in the era of where overlapping the 2014-18. So 2013, I can translate it to you as you are using it, really a little bit of small changes in the nodes, etc. But roughly when the disease is visible, we call it 1B. Again, it's bulky or not, clinical or non-clinical. If it's less than 4, non-bulky disease. But the main thing that you need really to differentiate is what they call it 1B, 3, when it's a little bit like, bigger than it should be, and it may metastasize to the lymph node. Of course, if it's extending beyond the cervix, it's stage 2, and if it's extending to the pelvic side wall, 3, and on. So you can choose whatever you want to do, but make sure like you are translating to what really run in the actual trial, especially the what changing the practice nowadays is the immune therapy trial, as well as the interlace that we will be going through. I need a volunteer from you guys. How would you investigate a patient and diagnose? This is, I don't need to do it, and I need to hear from you that I can give you some tips, because, I just want to make sure, you guys cover this. So if you have a patient that presented to your clinic as a surgeon, post-coital bleeding, a young patient, 30-year-old, what would you do? Who will be volunteer?
I will. Dr. Amira. First, I'll do the basics. I'll start with history. examination, I'm going to start by local examination. طبعا vaginal examination. So you have speculum, pap smear, endometrial sampling. Or if there's a clear mass, I'll take a biopsy. I have to do a local bimanual examination. And then the basics can before it was cystoscopy and examination under anesthesia. I'm not sure if we still use this or not.
That's very good, Dr. Amira. Any other volunteer want to change, or like, Dr. Amira mentioned that she will take a history, but can you give me not necessarily all the detail in the history? I used to be a surgeon, I changed my mind, but like what as a surgeon need to pick up in the history, quick things, and you want to make sure that you document it.
Is it postcoital bleeding or intermenstrual bleeding? Or is it
other than you, Dr. Amir, you did very well. Other than you, anyone from the group want to volunteer, what would you do in the history and also the examination?
History can include abnormal discharge,
okay,
abnormal uterine bleeding or vaginal bleeding. لو في history of sexual transmitted diseases.
Would you ask about any urological complications or urological manifestations? Urological.
اللي هو الاي في بي ممكن اعمل فكره لو هو شاكك بس هو نوت روتين اللي هو فكره الكولبوسكوب او الاي في بي صح؟
Would you mind to speak English, because I think we need to unify the other like audience. I heard they are non-Arabic speaking. So yes, so you want to make sure like you take the duration of the onset and duration of the symptoms, as well as the any symptoms that suggest like local extension, so urological or from GI as well symptoms, so that lead to like the local extension. Also the onset and the severity of the bleeding, if the patient have any fainting or any issue that suggests like she has severely bled. Also like very important, you mentioned that sexually transmitted diseases, because some area it's very endemic, like HIV, etc. And this is very important. So, and then you proceed to the biopsy.
Dr. Saad, sorry, we have some of our from virtual attendees, Dr. Sumaya Naji. She wants to participate and answer the question too, if she wants.
Sure.
Sumaya, can you introduce yourself, please, and you can say what you were willing to say.
Okay, thank you for letting me participate. I want to say about cytomegalovirus, not cytomegalovirus, human papilloma virus, which is the most risk of cervical cancer.
That's great. Yes. So sexually transmitted disease, any history of multiple partner, etc. So that's you need to document exactly. So that's really good. Now you proceed to the examination. So I appreciate you guys. Now, although we are depending more on the imaging and but really keep as trainee and even in your practice, you need to do the examination. Believe me, like examination tell you a lot. So what examination would you do? The local exam, leave like general exam. Someone from the surgical trainee.
So Dr. Sahar will answer it from Sudan.
Yes. Dr. Sahar.
I'd like, hello everyone. I'd like first to do an inspection by inserting a cuscus speculum. Then I try to evaluate the lesion size-wise, site-wise definitions. I might take a bunch biopsy, endometrial biopsy as well, by PIPL. Then I'll remove the speculum and do palpation by BV, then a bimanual, mainly trying to assess the parametrium and the size of the tumor, if it's possible, size of the uterus, the adnexia. Then I should finish up by doing a prerectal examination, assessing the rectal mucosa for direct permeation from the tumor. Then I might have a look also at the lower limb edema or due to lymphatic obstruction by the tumor, maybe sometimes. Thank you.
That's perfect, Dr. Sahar. Great. This is great. So you do the examination and you took the biopsy, everything. It came back, and it will come back. Sorry. But what would you order also part of your investigation? Someone else, not Dr. Sahar and others.
So we'll
Dr.
move to our surgical fellows, not our gynae fellows. So what will you add after the examination or anesthesia? What investigations would you ask for a patient with suspected cervical cancer?
Post contrast MRI pelvis, metastatic workup as CT chest, DNC, punch biopsy from the mass.
So yeah, so let's say from the lab, like guys, I want you to be a little bit like, maybe more organized. So let's think about, okay, a history examination already done. Now the lab investigation. So what would you do in the lab? This is like suspecting, as Prof Basil is saying, suspected cervix cancer, and what you want to do in the lab. I need 3 things from you guys. Always remember it.
I have to do a complete blood count, heading see if she's anemic or not, anemia mainly, and I'd like to do a renal function test as well.
So great. So you need to the biochemistry, like the CBC and also the hemoglobin. That's very essential, like upfront, and also the renal function. Because why the renal function? Sorry, quickly, I want to make sure you're grasping the fundamental basic. Why the renal function specifically in the cervix cancer?
Because it causes hydronephrosis, low extension through parametria. It's compromised.
Hydronephrosis is very important, yes. And then the serology. So you divide the biochemistry, renal function, and the serology. The serology you will do like the sexually transmitted disease, HPV, HIV, and also the other viruses. So you requested based on your whatever from your history, but mainly you do these things. And then you move to the imaging. What imaging would you do? So lab, we mentioned that you need to be organized, biochemistry, renal function, and serology, and then you move to the radiology. So what radiology you want to do?
Maybe transvaginal ultrasound or pelvic MRI with contrast, but MRI preferred to check extra pelvic disease.
So great what you are but I would say because we're preparing you for the whatever, like you're also like exam. So at this stage, we only did the biopsy. We didn't know if it's cervix cancer or not. We did like as presuming it's cervix cancer. If you are encountered with such a question at this stage, I would say we do a minimum of CT scan depending on where you are, CT chest, abdomen, pelvis, and then you stop until the things comes back. And whatever, like if you are in their examination, you're sure this is cervix cancer, and you may be moving to the MRI, but I would differ, like, the biopsy will come quickly and then you move as you're saying. So you requested the metastatic workup, which is CT chest, abdomen, pelvis, with the PET scan as well, depending on when your examination and staging, but you put it up front, and also the MRI for the local staging. So all of these things you need to mention. So great.
Sorry to interrupt. And the gold standard is MRI pelvis. So I don't know. Do we do a PET scan as a workup, a primary workup? And if
so
it becomes like negative, do we do a PET scan before if we decide treatment?
So again, it depends like with your like extent of the disease. Like if it's a very early disease, let's say like it's barely visible or like it's not visible. It depends on if it's mainly what we see more than 85%, and I'm sure even in Egypt and somewhere, is locally advanced cancer, the cervix that we're seeing. So probably you need to, it's becoming part of even the staging nowadays in 2023. So you depend on the nodal staging as well as where the metastatic disease as well. So yes, PET is becoming very essential. And let me just talk about it now, since we are mentioning why the imaging. Of course, it's non-invasive. It's different in the diagnostic as well as for the planning, as for the treatment as a radiation oncologist, and for the surgeon as well. If there is metastatic node, they probably will not foresee or pursue the treatment surgically. So yes, you definitely, once the disease is confirmed, you need to do the PET scan. And for the local and the extension, etc., yes, MRI is for the local staging. So you always mention and articulate well when you are encounter with any in rationaling your answer is for the local staging. You do MRI, you look into the activity of the disease, the diffusion restriction, the contrast enhancement, and also the extension locally, the nodes, and the sizing is more accurate and more particularly important in the MRI, as well as for the PET for the extent of the distance disease. For metastatic disease, you need the PET scan. Now, the FDG or the PET scan is becoming essential for detecting or discovering the disease, but also for treatment-wise. As radiation oncologists, it influences our decision for the treatment itself, because we based our escalating the dose or increasing the dose with the PET scan. So sorry, I put it like up front because I want to emphasize it's for diagnostic, also for the treatment. MRI also becoming essential. This is a pre-treatment for diagnosis, local staging, but also for you as a surgeon, you need to answer, it's important for the treatment, whether like for the surgery, but mainly for the radiation oncology with the brachytherapy or the boost, because you need to have a baseline without differentiating it bulky disease or not. So the PET scan, again, pre-treatment, under-treatment, and as well post-treatment. I know it may not be available for every country, but when it's available, you need to do it. And for the pre-treatment, 80% of the PET scan, even the node less than 1 centimeter, it is very accurate in determining where to really tackle the disease and boost with the radiation dose as well. It also decreases the chance of ruling out the PA node, and you do not necessarily extend the field as radiation oncologist to the para-aortic node, and also not to let the surgeon go after also the PA node. Although there is a formula that you guys need to remember, and the surgeon will tell you about it, that the chance of PA, if the pelvis is positive, etc. But again, for the imaging now, it's replacing that assumption that you didn't need to postulate about what's the chances the PA node. So the PET scan will annihilate this assumption. Any questions so far before we move to the treatment?
So I believe everything is clear, Dr. Saad. So for us as a surgeon, we usually start with the transvaginal ultrasounds, and then the MRI is the gold standard for local staging, as you have mentioned, to see the extension to the perimetrium and to the bladder and the rectum, blah, blah, blah. As you believe, most of our cases are in advanced stage. So only with examination, we can refer directly to you after examination without even doing any radiology, just with examination, having the biopsy, and then sending to the clinical oncologist to assess the definitive chemoradiotherapy is going or whatever the treatment. But if I'm in borderline between the locally advanced and the early cervical cancer, we depend on the examination and the MRI to see the delineation, the perimetrium, the vaginal infiltration, and all of these things. If it's okay for us that this patient may be surgical, we will proceed for a CT of the chest and abdomen. We do believe in the laparoscopic assessment of lymph nodes rather than the PET CT sometimes. We have the PET CT already in our institution here in OCMO. However, we also depend on the laparoscopic assessment of the para-aortic and the pelvic lymph nodes. And if we have a node-positive disease, I know that the practice is to refer for chemoradiation, but if I have only pelvic lymph nodes and we are going to change this in the guidelines for limited resource setting, we can proceed for radical hysterectomy plus lymphadenectomy in the limited resource setting if you have the lack of radiation therapy. But in a high resource like Riyadh, definitely with positive node, we will refer to the clinical oncology at once.
Absolutely, Prof Basil, I second what you are saying, and I think this is, what the comprehensive that, thank you are outlining. Laparoscopic also from surgical point of view, yes, it's probably more accurate than the PET scan, but once you rule out it's not a surgical disease and it comes to the chemoradiation, definitely, as I mentioned, you need to feed the PET scan to make sure that, the disease is well understood before you plan the patient. I totally agree, yes. So for there are some guidelines for the treatment. Now, once you diagnose the patient, and as Prof Basil mentioned, it's either surgical or non-surgical, you need to decide it's a surgical management or non-surgical management. Of course, very simple. The non-surgical management is the definitive chemoradiation nowadays, with more maybe chemo before, and also maybe immune therapy with the chemoradiation that now changing the practice nowadays. But I need just to touch very lightly on this is the executive summary for Astro. Divide the patient from 1B3 to stage 4. If those patients from 1B3, again, depending on the local context where you are, this is based on North American practice, you need to do chemoradiation nowadays with immune therapy again, or neoadjuvant and then CCRT. If it's less than 1B3, then you need to talk about the surgical management. So for the radiation as a primary management, I want to talk about the trial and then we will summarize, of course. But guys, really very important for you as a surgical trainee to know the radiation trial and perhaps some chemotherapy trial. Very important as primary modality for you, even you refer to the other, you need to definitely know this trial because that will strengthen your decision-making as well as making sure you don't operate in a wrong patient or you do not even serve the patient with the surgery if you don't know them. So this is the gold standard for radiation oncology, the Milan trial, long time ago in the 80s that divided the patient. This is again old staging, 1985 to from 1B, which is probably more than gross or more than, sorry, bulky disease, and to A, which is extending to the beyond the cervix. And then they gave them radiation or radical surgery. I know it's not clean trial, but there are some, when the disease is more bulky, there are some patients that require adjuvant radiation therapy. And as you see, more than 60%. And this will increase the complication post-treatment. So in a surgical management for you as a surgeon, and especially for your exam, you need to give the pros and cons. But I summarize it for you because, you know, the reason I'm giving you this, I want to guide you and give you some tips. And I know you will read your textbook, you read the radiation oncology, but I can't give you these tips. The choice of the surgery depends on many things. To make you more organized, the stage of the disease and the size. So when it's a bulky disease, the surgeon knows if it's a bulky disease more than 4 cm, you probably need more adjuvant treatment like radiation. So you're probably not needing to add more modality if you only serve the patient with one modality. So this is one argument. Lymph node status. If the patient having positive lymph node, you know there is a trial that I'll be talking about. If the node positive, you need adjuvant treatment like radiation and chemo as well. And patient age. Some patients, they are elder patients that they may not fit for surgery. And certainly I know, I practiced and trained also in a Western environment. The North American patient, not like our patient, like in Middle East in general. They are more young or younger than our patient. I'm seeing here, like as I mentioned, we treat huge number of patients, smaller the patient, like over age of 50, 70. I treated 85-year-old lady just like a few weeks ago. So it's a different environment with different disease. So patient age also matter. The type of the surgery, again, it depends on if the patient desiring the fertility or not. And they may go for surgery because they want to spare their fertility if it's very early disease rather than even needing radiation. So the pros allow of accurate staging. This is again, maybe argument now if someone is asking you is a little bit soft because accurate staging nowadays is probably with a biomarker like the MRI and the imaging, the PET scan, maybe making it less important than before. It used to be. Ovarian preservation, especially with the young patient, absolutely. It's one of the pros for the surgery. Fertility preservation, reduce the total treatment time, definitely. Nowadays, if you tell the patient you go through 30 days of treatment or you go for maybe 3 days with total treatment after the surgery, and then you will be discharged home. So definitely this is pros. And acute side effect definitely is less, and also long-term side effect. There is no doubt the surgery is better for the acute and long-term. But the cons is the morbidity of the surgery again. There are some, if there is injury to the surrounding structures, risk of the requiring adjuvant treatment. I would say not the surgical morbidity, but requiring adjuvant treatment is the biggest hassle for shying off of the surgery. Role of radiation that I mentioned, I summarize for you here, is the Landoni trial or the Italian trial. You can just refer to this if someone is arguing with you for any treatment decision. From 1B, again, it's a bulky, not like 1B that you're seeing in 2023. But if it's more advanced disease, more than 4 cm, definitely you increase your chance for adjuvant treatment. And post-treatment is required. So for early, more than 4 cm, there is a question, but as Prof Bassel said, it depends on the environment. If there is limited resources, you probably will surgeries those patients. But if you have full comprehensive mature resources, you'll probably say, okay, I may manage them with radiation alone, which is unlikely, and I haven't really treated a patient with radiation alone yet, but definitely with chemoradiation or immunotherapy. Needing radiation after surgery for early disease, this is the trial that you will be referring to. And these are the criteria. I'm not only putting the trial, but when you're on tumor board and you maybe encounter with the patient. So lymph node and negative, but there is intermediate risk disease if there is deep invasion, and especially more than 4 cm disease. That's increases your chance of metastasis to the lymph node, and you need to address the pelvis. That's the rationale. You need to go after them for surgery and increase the local recurrence. And the GOG 109 for the chemoradiation, there's positive lymph node parametrial involvement, and also if there is any positive margin, which is probably you'll encounter if the disease a little bit advanced. It depends with your practice. But those patients need chemoradiation and increase the overall survival roughly by 10% if you give the chemoradiation as adjuvant. So all of you, I want you to really memorize this slide. Any questions so far? Because again, the lecture is about the adjuvant treatment. And for you as a surgeon, this is very essential. Any question around this?
Yes. So, Prof Saad, it's again about the need if you will combine the two modalities, the surgery with the radiation therapy. Usually, we do all agree that the dictum is to try to do your maximum effort not to combine post-surgery or radiotherapy, either surgery or radiotherapy. But always we have this gray zone of the cases of 1B2, 2A disease, where you have a tumor which is 4.1 centimeter, 3.5 centimeter. I have just a lady last week. She was 34 years old, presented with squamous cell carcinoma, grade 2 non-characterizing squamous cell carcinoma. The tumor size by the MRI was 3.3 by 3.8 centimeter, okay? With no nodes, and I examined her around, the parametrium was free. A surgeon saw her and he referred her for definitive chemoradiation. And I really knew that this patient mostly will have radiation because it's a 4 centimeter tumor and mostly will have adjuvant radiation before. But when I examined, I found also parametrium all around. It was free. The fornices were free, and she was a node negative. So I told her she's 34, and I wanted to preserve her ovaries as well. She's a squamous, not adenocarcinoma. So I performed for her a radical hysterectomy, a type C hysterectomy, and it was really nice. I have a good vaginal cuff margin, more than half the vagina, and I removed the lymph nodes. Today I received the pathology specimen. She was the parametrium was free, the vaginal margin was free, but there was lymphovascular space invasion, there was deep stromal invasion, and there was 2 lymph nodes out of 60 removed lymph nodes. So 1 lymph node in 20 right pelvic lymph nodes, and 1 in 20 left pelvic nodes, and the 20 para-aortic lymph nodes were free. So we have 2 out of 60 removed lymph nodes were positive. So she was upstaged from 1B2 to 3C now, okay? Of course, absolutely. She will need with all the risk factors, she will need adjuvant radiation. I already transposed her ovaries. I removed her ovaries away from the field because in the surgery, I knew this patient mostly will need post-operative radiation. So, but again, my question is, I really believe that if I'll combine surgery with radiation, I'll try to start with surgery, because surgery before radiation, the morbidity would be much, much less, rather than doing radiation and then having a residual disease and then doing a salvage hysterectomy, which is hell for us as surgeons and for the patients. So if I have to combine both, I'll start with surgery. I don't know if you agree with this or not.
Yes. Prof Basil, I have to say, and even I work with the surgeon and like in a different area and different even country. I know your professor, not every like surgeon like, your practice. Like if I believe the surgeon is so making sure the patient that you mentioned 3.8 and no any other extra extension, etc. So when it's coming from the way you are summarizing it, I will forgive it and say yes, definitely. I trust, and of course, like with the surgery, who you will be trusting. Like you don't like trust everyone, unfortunately, especially when it's coming into this gray zone. But if you have, as you mentioned, limited resources, and you want to make sure your stage held very well, and you may be adding radiation, maybe radiation is okay. But the issue, Prof Basil, is if you add chemo radiation, maybe it becomes a little bit like, too much. But if the patient, like as you mentioned, if she preferring to preserve her, like you did a great job with her preserving the ovaries, which is great, and transposition of the ovaries away from the radiation, then the radiation side effect will be not that like, high. Nowadays, I have to say, Prof Basil, is these studies, Landon trials, etc. It was done in the era where the radiation is too much risky for doing or inducing side effect. Nowadays, the radiation is more conformal. There are more technology than before, and with the IMRT or the conformal radiation, it is way better than sparing of the organs. So I would say the side effect of the radiation is not the same what I mentioned in Landoni, but as fundamental for the trainee, if you prefer not to combine the modality, that probably you need to go for. And if you do one modality, is better than adding modality, because the summation of the two modality may increase the side effect. That's hypothetical. Although, like I'm seeing, I'm treating a lot of adjuvant patient, and the side effect is really not like that big.
Exactly, Dr. Saad. That's what I'm saying, that the morbidity of surgery in good surgical hands is not that fearful. It's easy, and the complications of the new generations of radiation modalities is minimal. Okay. So I don't know exactly why in the cervix we are very afraid to combine modalities. We combine the modalities in the rectum, in the breast, in lots of in the head and the neck. Why is this fearment of combining surgery with radiation, especially in the cervix?
Absolutely. If it's only, early, like, 4 or like the size, what matter, I think, we may be a little bit of like, okay of combining. But the issue is if it's, with nodes, etc., that, that will put more like, morbid things. But I definitely agree, nowadays is way better than.
But we have to respect the evidence till we do our evidence. We have to respect and we have to follow the evidence. This is the dictum. Yeah.
Yes. So these I summarize for the intermediate. Again, I summarize you the trial. So you need to memorize, all of you, this cartoon that I put for you. What are the indication for the adjuvant radiation? Large size, more than 4 cm, LV size. As Prof Basil mentioned, the patient has, now it's focal VSI less than 3 spaces with your pathology. You probably may forgive it, but it's more than 3 spaces. It's extensive LVSI, and then you need to follow or like interpret as LVSI needing adjuvant treatment. Of course, the stromal invasion, it's more than half. That's, you need to do. And these things interpret like the local recurrence as well, the overall survival. For the adjuvant chemoradiation, the 3 Ps, parametria, positive margin, and positive nodes. So all of these you need to memorize. If you just leave from my lecture for the adjuvant treatment, you need to memorize those 2 for any exam, for any tumor board, for your life, unless the evidence will change in the future. I know it may be coming. For the, now we move into if the disease more locally advanced, very simple. Honestly, you didn't need to think about the staging, etc. If more than 4 cm, bulky disease, now you think about what else. If there's nodes, positive nodes, it's considered locally advanced. I know there is more some controversial between the trials and the definition, but it's clear. If more nodes involved, more disease, fulminant disease in the abdomen and the pelvis, and PA nodes, hydronephrosis, all these things considered locally advanced. Of course, extension into the organs in the pelvis, considered locally advanced. but those four things that you need to remember without even going into your staging workup. So with the locally advanced, what I need you to remember is there is a meta-analysis, but just to reassure everyone when you are talking in a evidence-based medicine, there are many trials, the GOG's trial, the SWAG, the American California trial, the RTOG as well, all randomized trial that driven the benefit from the chemoradiation since 1999 that give a minimum of 10% overall survival if you do chemoradiation for locally advanced. Of course, I summarized some of you, but for the trial, but that's, you didn't need to remember everything, but you need to remember that it increased the overall survival, the most important. It also reduced the local recurrence and the needing for other modality. Of course, there is toxicity for anything we do, but definitely nowadays, as Prof Basil mentioned, with the surgery and the radiation, the toxicity is becoming less and less. So here is what you see, 15 randomized trial, as I mentioned, non-platinum with mainly the cisplatin. Sorry, I should ask this. What chemotherapy we give? I already mentioned cisplatin, but how much? What's the dose you give, guys, the cisplatin? Any volunteer?
We don't have medical oncologists here. Amira is saying
all
something.
surgery.
Yeah.
Yes. I think we'll give them like, you know, a bonus, Prof Basil, if someone from the surgical. Yes.
No, please, I don't want the bonus, just no embarrassment. Is it 75?
75, maybe with the other cancer, maybe. So why we give the cisplatin? Very important. Again, our emphasis today is not only like, you know, giving you we need you to be mature in the fundamental. So why we give the cisplatin? 2 reasons for the cisplatin, maybe 3 reasons. And if someone is asking you from like your examiner or someone is asking you. So one is the radiosensitizer. What does it mean, radiosensitizer? I mentioned already when I was talking about the radiobiology. So making the cells more susceptible to kill. So you need to prepare them to be vulnerable to be killed with the radiation. So when we give the cisplatin, it gives the cells to be ready to be killed by the photon or the X-ray when we give the radiation. So radiation sensitizer make the cells more susceptible to be killed by the radiation. Number 2, always I ask the resident, even here they don't mention, even the radiation oncology resident, unfortunately. So it gives overall survival, guys, benefit. If someone is examining you, why I give it? Because this is chemotherapy. It gives the radiation sensitizer. It gives the overall survival benefit, which is the most important. So the dose I want you to always mention is it's given weekly, once weekly, during the radiation, which is 25 sessions, and it is given with 40 milligram per square meter. Okay, 40 milligram. So you need to remember that.
40.
Not many that you need to remember, but for you, I think Prof Basil will mandate that in your exam. He will ask you.
Yeah.
So now we've been doing this for the past, I would say, in my practice, like the past few years, and it's been done for so long. It's chemoradiation for the local advanced disease. But before you do the chemoradiation, what thing you want to do for the patient? Like, let's say the patient has hydronephrosis. I'm giving you this, like, just before we move forward. What would you do before you give the cisplatin? Would you give the cisplatin, or you didn't give it? I know you're not interacting with, you're not medical oncology, but you need to know this information because you guys are doing this. The patient will be referred to you. So kidney function, huh? So if the patient has hydronephrosis and the patient, what would you do for the patient? You send them for the urology, and Prof Basil, I'm not sure the practice. Do you guys do it by yourself, the stent, or what? Who's doing it, the stent?
No, we repair it to the urologist here. The urologist will either insert a double J stenting, or they will do a PCN. If things are sostenosed and they can't insert the double J, they will put a PCN, but they will start trying with a double J.
That's perfect. So for you guys as trainee, you need to remember that you need, before you give the treatment, you need to do the stenting because it's very important before you give that. And would you give the cisplatin or you give something else? What do you suggest?
They don't give, Dr. Saad. They refer to the medical oncologist.
Okay. But they will be attending the tumor board with them, and then they may be like, okay. So for you, just for your information, you may give the non-cisplatin chemotherapy, the platinum-based, like the uterine style. So because it's like a little bit gentler, the cisplatin is more tough on the kidney, the ear, and also on the other CNS organ. But when they have hydronephrosis, it's very difficult to give the cisplatin, and you may give the carboplatin as well.
Sorry,
So,
Dr. Saad, we have a question from Dr. Mohammed Al-Husseini. He's a surgical oncology fellow.
Dr. Saad.
Yes, Dr.
To ask a question, please. If patient had CKD, you will give cisplatin?
So in renal failure, it depends. If the kidney is not functioning at all, you probably you need just to document that with a nuclear scan, and then you say, okay, you're giving it, the patient. But if maybe CKD because of the hydronephrosis, it may be like reversible. So you need to do the alternative, which is the uterine style treatment. Overall survival not good as the cisplatin, because the cisplatin was run, as I mentioned, with every trial. Here's some, if you see here, there are some trials, the American trial, that they did carboplatin as well. But again, the overall survival not good as the cisplatin, because cisplatin is, as for us, is more potent as a radiosensitizer, and also increase the overall survival better than the other chemotherapy. So you need to evaluate, but in general, no. For example, I know you're a surgeon, but you may be encountering your exam that as a general knowledge and fundamental, you don't give it in your exam.
Sure, they will encounter those questions in the ESGO exam for sure. And I'm very happy with the discussions that you are running.
Absolutely. Otherwise, Prof will say, see you next year.
I will not examine them. I'm just training them. The ESGO will examine them.
He's in the examination board, however. So maybe some bribes.
So this is very important. Yeah. So don't give it in your exam. Say, talk as I'm talking about too much about it until they stop you. Then they will think you are safe. Okay. So now we move from the CCRT. Again, we're sitting. If I ask you overall survival benefit, overall survival for the patient with local advanced, maybe for the European exam or your exam, you say from 50 to 70%. Again, it's like a large margin, but it depends if hydronephrosis, PA nodes involved or not. If you do CCRT, what's the expected overall survival? You say 60%, perhaps to 70%. I would say this, stick with this number. This is with the CCRT. Now, with the new things, maybe there is a little bit of increase. It's sitting around 75 or 80%. So the overall survival has improved. So the recent one that came, you probably now need to know, the interlace trial. So it gives, I can summarize, you can go through the slide, but I can summarize it. So it's early disease needing chemoradiation, meaning the same soft area that Prof Basil is mentioning, it's above 4. There's some nodes involved, but not like extensive disease, but not the actual very locally advanced disease. So that's what the protocol of interlace. So it's not a huge like with PA nodes or hydronephrosis, etc. So it's a little bit of limited disease. And again, it started long time ago. The radiation was not the best. The brachytherapy was also not the best was delivered here. So that's the cons of this trial. So they gave chemotherapy, carboplatin. It's again uterine style, and giving it for 6 weeks, and then move to the either the standard CCRT or just placebo part, which is non-induction CCRT alone. And the CCRT cisplatin 40 milligram per meter square weekly for weeks. And with the radiation, again, 40 to 50 gray. That's the European practice. And again, the brachytherapy was a little bit dose, was not the best. And maybe the chemotherapy compensated. So the trial was positive. So increased overall survival, better overall survival, and better local control as well. So in some area, if you have available resources and you have, again, patient needing CCRT, maybe you need to talk about giving induction before. I have to say when I came here, there are some patients, especially in the South, that they don't have radiation therapy. And I start with inducing them with chemo, waiting them to be accepted in Riyadh. And I saw even before the disease moved so well, because, it's squamous. And when we start the CCRT, there is no disease there. And even following up with them, we did a little bit of retrospective review, way better. This is before the interlace. But of course, the interlace is the randomized trial. It came now, and it altered definitely the practice. Now, what I want you really to emphasize is the immune therapy, the keynote 18. This is probably what changed the practice, and what, if any center have available or access to the immune therapy, especially if you are writing or examined by the European board, this is what you need to talk about. And I bought intentionally this because I need you to remember it. So this trial came for locally a frank, true, local advanced disease, more modern radiotherapy, better brachytherapy, better everything, delivery of chemotherapy with the immune therapy. So in my view, this is the study nowadays that really altered the practice. So it gave the 2014, again, bulky disease, 1B now 1B3, which is not 1B2. And with positive nodes, as I mentioned, local extension, hydronephrosis, PA nodes, all the local advanced disease. And again, more bulky disease than even with the interlace, which is very selective in some patient. And they gave the radiation, IMRT, as you see here, BMAT, which is the new technology. And the patient was well staged according with also some PET scan, especially after 2018 before the closure. And they gave more than 80. This is the planned total radiotherapy dose, but I was reviewing with them the protocol recently. It was actually more than 80 gray. So they gave the actual dose to the cervix itself. And they gave the cisplatin 40 milligram Q weekly for 5 cycles. Of course, 5 cycles because you give 5 weeks of radiation. And then with the radiation followed by brachytherapy. And then concurrently, they give the pembrolizumab, 200 milligram Q3 weeks for 5 cycles. From the trainee, what is the pembrolizumab? Anyone can answer me?
immune check therapy.
Okay, so it's immune. Okay. What do you call it? PD-1 inhibitor or PD-L1 inhibitor?
PD-L1.
Excellent. Guys, even you are surgical trainee, you need to remember these things because that's very important for you. Because you are oncologist, you are not only surgeon, because the training that you will be mature 3, not only like you're not going to be graduated as only pure surgeon, you will be like oncologist. So you need to know these things. Okay, the pembro was giving during the chemo radiation, so Q3 weeks. So likely if it's giving during the radiation, so week 3 and then week 5. Week 6, because it will be given every 3 weeks. So when the patient start week 3, and then when the patient finish, and then maintain for 15 cycles, or the experimental arm, the standard arm, the cisplatin with the standard of care. So what did it do? So of course this is like you need to go through it. Like I don't have time because I think we have a constraint of the time. But then they follow the patient. They stratify them 1A, 1A2, which is bulky and unbulky. 1B, 1B3, and then the PDL status now with the immune therapy less than 1% or above. It's not important anymore because nowadays immune therapy is given to everyone almost. They stratify them about this is their morphology, etc., and the treatment exposure, how many completed or not. Now, you need to know those patients, most of them, they completed the treatment. Even the chemotherapy, CCRT, the patient that completed around 70 to 80%, by the way. Here, almost most of them, they completed the immune therapy and the chemotherapy together. You see here, the 24 months rate, there is a huge separation of the curve for the progression-free survival, the overall survival. You can see here the overall survival. There is split from 7. Now, as I mentioned to you, most of the chemotherapy trial sitting between 70 to 75, that's the overall survival, but now it's pushed above the 80%. This is, again, I remind you, this is very advanced disease. Most of them, they are PA node positive, gross disease. So getting 80% with the 3 years, really like amazing with for the cervix cancer. So for you, the immune therapy plus CCRT, for local advanced disease, I think you should be, this is your answer, and for your recommendation for any patient from now on. Again, this is across the stage, age, and morphology. The stratification, this is not very important, but also showed really substantial benefit from the immunochemoradiation. So in summary, this is their own summary. Took it from the, it was presented a few months ago from MST. But if you need to give the CCRT, especially local advanced, give the Pembro, please. So that's, I guess, this is what the most important nowadays for the adjuvant and radical treatment. Any questions so far about what we talked so far?
So the message is give Pembro with the chemoradiotherapy if you are living in Riyadh. This is a very important message. So we are trying to introduce more and more immune therapy really here. In Egypt, it is now affordable for some private sectors, and even we tried by some charities to do it. It's still not covered by the insurance and not covered by the government. But I believe in 1 or 2 years, it will be covered with the presidential initiatives, as what happened in the breast and other organs. But what you have to know as a surgeon, to ask for the BDL testing, for example, and know the BDL scoring, if it's BDL score 0, 1, 2, 3, like this. So Dr. Saad, really, it was an excellent presentation, and the how you circulated and the discussions and how it went, this was very innovative and very nice. And I have many positive feedback from our virtual attendees. They are all saying very good feedback about the discussion. Thank you for being with us, and thanks for your time. And he's still here. Some slides, yes.
Yeah, Prof Basil, yeah, no problem at all. As you mentioned, thank you so much for even telling me what you're doing. I think, yeah, you're right. So it's not covered with every countries. I mean, if you can, honestly, you need to push it, Prof Basil. I think, it's really changing the way we think about the cervix. And for the trainee, especially if they are doing the European board, I think they need to answer this regardless. And, they give the feedback that, accessibility for the medical.
They must.
Yes, they must, absolutely. If you may allow me, I may give, I don't know how much time, I'll give them a little bit about brachy just to know what we are doing. And brachytherapy, quickly, I will not stop a lot. Unless we don't have time.
No, we can have more 5 minutes, I believe.
Okay, then I'll fly quickly. Just overview. I know it may just give them a little bit of thought process about, especially with the cervix. So brachytherapy is really what we believe in is giving almost the same dose with external beam radiation, but really in 3 or 4 fractions. So when you introduce the source inside the cervix or inside the disease, you give a substantial dose that you cannot give with external beam radiation as you are doing. So really, this is very important concept nowadays. So to eliminate the bulky disease as well as the microscopic disease, and it's the best or the biggest the dose escalation ever you think of. Again, this is the evidence where you have to do it after the external beam radiation. So when you give the 25 fractions, you have to follow the cervix brachytherapy for definitive. Otherwise, the patient is not treated if you don't follow with the dose escalation brachytherapy. And we do it under anesthesia. I will go out our process. We'll do a spinal anesthesia here. You can see we publish about the spinal anesthesia is the most important. This is one of the papers that, if you have time, I published a few years ago about the toxicity for the brachytherapy. You may need to read about it. And we introduce here a lot of techniques. So this is the interstitial one. Again, from the cylinder to the various interstitial needles. And this is what they call it, the Fletcher applicator. You put all the metallic the tandem inside the uterus, and then you put the flange or the two ovoid inside the vagina, and then you insert your needle oblique or lateral. Then you pierce the parametria as well as you reach somewhere in the pelvis. And this can give you a really huge coverage for the disease, especially the parametrial disease. This is, again, interstitial technique only done in our center. Introduced it in 2022. So they call it the 3D interstitial applicator. So you put the applicator inside the vagina, inside the uterus, the tandem, and then you insert the needle. And the way you want, even the disease extending beyond that, you cannot treat it with a traditional brachytherapy. So you reach all the disease around. This is the ARAS from the Denmark, and also designed the way they are. And again, the same concept, and then you insert the needle. Here you can see the disease here. You reach and far and beyond, because in the parameter we reach around 1 or 2 centimeter lateral. With the interstitial technique, you reach up to 4 centimeters. So really, like, it's telling. Now we use the ultrasound-based technique. We insert in the rectum, and then we guide the needle. And this is, if there is no uterus, for example, the recurrent disease, we do the template-based, or they call it the Kelowna Canadian city-based template, where design is. And then you insert from the perineum, and then you place the needle where you want your disease. This is the Kelowna technique that adopted here. You come from, especially for the recurrent disease, we did not talk much about it. Any recurrent disease nowadays, we don't do much really like the concentration. We treat with the definitive brachy and radiation, so we can reach give an adequate dose there. So that's what I want you to know, that there is some techniques that even with the radiation that you need to remember, and if it's available, you need to refer the patient to. Sorry, I make it lengthy, but I hope it contributes.
No, it was very, very interesting, really, Saad. Thank you so much.
You're welcome, bro.
So we'll have a space, I believe, for 1 or 2 minutes for anyone who want to ask Dr. Saad from our virtual attendees or from our physical attendees. Do you have any questions for Professor Saad? Yes, Amira.
Doctor, thank you. That was wonderful, really. I wanted to ask about the dose of radiation for brachytherapy. Is the dose higher towards the end, or is it towards the base? Yeah, towards the fundus, or towards, I mean, not the fundus. The probe goes all the way from the cervix till, I believe, the mid body of the uterus, well, till the fundus.
So we cover, so usually, like, we go with the guidance of the surgeon, the same with the concept that you understand. So that mainly the cervix through 3 to 4 centimeter, like, roughly in any ladies, depending on the uterus, how long is the uterus. But really you need to cover from, the external os up to 3 centimeter toward the uterus. And in we use the MRI, and of course, like with the examination, and with the we do ultrasound based during the brachytherapy, and really we will make sure the whole cervix is covered. So most important, we want to cover the cervix, which you need to geographically push the dose and give this like high dose in the cervix. So I would say 3 to 4 centimeter into the uterus, but you didn't need to cover the whole uterus.
And is the dose that is delivered, it's the same from the probe outwards, or is it higher, closer to the probe?
So it's symmetrical. So when you go from like the probe from like, entering from like the external os up to the entering to the uterus, so you will be covering the whole, this area will have the whole same dose. So you'll give the whole this mapping. After you do the mapping, you give the whole dose there.
Yeah,
now, uterus, it's a good question. So the uterus received from the external beam radiation, remember, and we consider it microscopic disease. But this is very great question, by the way, from the surgeon. Probably compared to radiation oncology, I believe. So
No.
the uterus, we put it
No,
in
no,
the
not
ovaries,
exactly.
everything.
I like
We
surgery.
could put the 45 gray. And then this extra dose, which is almost the same what would give, but with only 3 fraction, we give only into the cervix.
Okay.
So
شكرا دكتور يعطيك العافية.
we have a question from Dr. Mohammed Al-Banna. He's asking, what about limited resource setting where there is no brachytherapy or pembrolizumab? And let me answer this question, Professor Saad, because already, Mohammed, we were last week preparing the ESGO guidelines for limited resource setting. So just wait till February and try to join us in Rome in February 25 to know the guidelines, ESGO guidelines, when there is no pembro, there is no brachytherapy. It's already formulated. We will finalize it in Prague in January. And of course, being a part of OCMO, you will have the draft before Rome. So I can answer this before Rome, but we will launch it in Rome 25, I hope. But to know the standard until now, if there is advanced, refer to Professor Saad or the clinical oncologist to do the definitive chemoradiation. They will add pembrolizumab. Okay. And if it is early, go for surgery. If it is blue 1B2, okay. And more than this, you will refer to have definitive chemoradiation. He may start like interlaced trial with chemotherapy in some situation to downstage the tumors, then go to definitive chemotherapy, to definitive chemoradiotherapy after having the neoadjuvant chemotherapy according to the interlaced trial, or he will give the chemoradiation and add the pembrolizumab according to all the trials that showed real progression-free survival and overall survival benefit for that. This is the guidelines worldwide. For the limited resources, wait for our guidelines in February, inshallah. So any other questions from the audience? We have another question. No, Dr. Banna is just saying thank you, Dr. Saad. All the audience here are thanking you so much, Saad, for your time and for the wonderful presentation. Any other questions from our physical attendees? So thank you everyone for staying so late with us tonight. Next week, I'm going to speak about the exentrations and salvage hysterectomies in advanced and recurrent disease. So I'll say when we don't have brachytherapy and all these modalities, you may go to exentration. Thank you, Professor Saad, and hope to see you physically so soon in Cairo, in Riyadh, and whatever we'll meet. I'm sure we will meet lots so near. And thanks for everyone who stayed to us, and good night. Have sweet dreams. Bye-bye.
Thank you very much. Shukran.